This is going to be the first part of the 3 series. This class is basically meant for the non-ICU staff in our hospital because in case we are having a lot of overflow of COVID-19 patients, the non-ICU staff may ask to come to the ICU to treat the ventilator patients. So it is always better to have some idea. Hope the situation doesn't arrive, but we had enough time. So failing to prepare is something like we are preparing to fail. I will be discussing in 3 points. One, the basics of ventilation. This is related to the COVID-19 part, that is basically the hypoxia or the ARDS part. And second is about the basic troubleshooting. It is essential to know about the basic troubleshooting because if things gets busy, it is very difficult to find the intensivist or the respiratory therapist on time. So probably you have to treat the patient at least for some time. So you have to know the basic troubleshooting. And third point is how to communicate to the intensivist or consultant about the ventilator so that he will able to understand what is actually happening in the patient if you are giving a phone call. Coming to the respiration. Respiration, the main idea is to give oxygen up to the level of the alveoli. And second is the carbon dioxide removal from the lung. So whenever you are connecting a patient to a mechanical ventilator in the COVID scenario, you will be expecting two things. One, to replace the function of the lungs, like one, replacing the oxygenation. Second is the carbon dioxide removal. How it is possible? It is possible through several modes. There are a lot of modes in the ventilator like SIMV, we are having ACVC, we are having ACPC, we are having ARPV. There are a lot of modes are there. We will be sticking our discussion to two modes. One is assist control, volume control, and second is the AC pressure control. So today we are going to discuss about the ACVC part. What is ACVC? It's basically assist control. It assists the patient breath. Is mainly through the volume control. So you have to know what is actually volume control. If you are comparing your lung to a balloon, it is like filling the balloon with a specified amount of volume. Say you are filling the balloon with a 50 ml of syringe. So once you start inflating the balloon gets inflated. But if you try to inflate it too much, at a particular point of time, you will start bursting the balloon. This thing can happen to a lung also. We want to avoid this. So if you are having some methods to know what is happening inside the balloon, like a pressure, it is going to help you in preventing the damage to the lung. So in ventilator, to measure the pressures, we are having three values. One is the P peak pressure, second is the P plateau pressure, and third is the driving pressure. So I will try to explain these three things. What is P peak pressure? P peak pressure is basically the pressure due to the airway resistance. So whenever you are giving air, it should pass through the trachea to the bronchus. It depends upon the endotracheal tube, it depends upon the circuit, and depends upon the humidifier. So it is the resistance of the air to flow through the circuit, the filter, the endotracheal tube, the trachea, and finally to the bronchus. So once again, P peak means the airway resistance starts from the circuit, your humidifier, endotracheal tube, trachea, and to the main bronchi. So what is P plat? P plat is an important thing we have to understand. P plat is the pressure at the alveolar level. Our alveoli is going to be the most functional thing in the lung. It is a very delicate thing. So if you're trying to increase the pressures in the alveoli, it is going to damage your alveoli. It is going to damage your patient also. So always try to keep the P plateau pressure within the normal limit. If you're trying to increase the P plateau pressure, you're going to destroy your alveoli. But in case of P peak, because it is going through the circuit and trachea and the main bronchus, it is capable of tolerating some amount of high pressures. But in case of alveoli, it is going to damage it. So we don't want to damage our alveoli. So P plat is basically about the pressures in the alveoli. So coming to the third is the driving pressure. It's the pressure which drives the air into the lung for the gas exchange. So how to set your ventilator? For setting ventilator, we need 5 things. We have to know our mode, we have to know the FiO2, we have to know the PEEP, we have to know the respiratory rate, and we have to know the tidal volume. Mode, as we discussed, is going to be ACVC today. So there will be total 4 parameters. It's going to be your FiO2, PEEP, respiratory rate, and tidal volume. So how to set? Before going forward, I like to mention about the PEEP. PEEP is the positive inexpiratory pressure. Suppose this is your lung and this is the airway. So if you try to inflate during inspiration, your alveoli get expanded. During expiration is getting collapsed. Again during next inspiration is getting expanded, and during expiration is getting collapsed. So if this happens, it is going to damage your alveoli because alveoli is having a very thin membrane. So what you can do is that after inspiration, you keep a minimal positive and expiratory pressure. So if you are applying a positive pressure at the end of the expiration, it will prevent the alveoli getting collapsed. So this is the usefulness of PEEP. So again, next aspiration, your alveoli doesn't collapse completely. Once again, PEEP is the pressure applied by the ventilator at the end of each breath to ensure that the alveoli is not prone to collapse. So it is keeping your alveoli open throughout the cycle. So how to set the FiO2? Initially it's always better to start with 100, then you can titrate. PEEP, you start with 5, probably have to go it high depending upon the condition of the patient. Tidal volume, you can go around 6 to 8 ml per kg. This is based on the ideal body weight. The bottom of the screen I have given the equation for the ideal body weight. And respiratory rate, we can start around 50. As I said, this is basically about the oxygenation, carbon dioxide. So what does the parameter do? FiO2 and PEEP are two parameters which help in oxygenation. So basically if you want to increase the oxygenation, you can either increase the FiO2 and you can increase the PEEP depending upon the compliance of the lung. What about the tidal volume and respiratory rate? This is basically for the carbon dioxide removal. So you can increase the carbon dioxide removal by either increasing the tidal volume or the respiratory rate or both depending upon the compliance of the lung. So if you want to decrease the oxygenation of the patient, you can come down on the FiO2, you can come down on the PEEP. Again, if you want to decrease the carbon dioxide removal, you can come down on the tidal volume, respiratory rate or both. Second thing we have to understand, how to know whether the patient is ventilating properly or how to assess the patient on ventilator. And second, how to know whether we are harming our patient lung. So coming to the first question, how to know whether you are ventilating properly or adequately. For oxygenation, we can depend upon the saturation, the pulse oximeter. If you're having an ABG, you can follow the PO2. So keeping the saturation the normal level or keeping the PO2 the normal level is an indication that you are oxygenating properly. What about the carbon dioxide removal? You have to get an ABG. ABG is also helpful. So you can see the PCO2 and pH, which will give an idea how much is the carbon dioxide removal happening in the lung. I will give a scenario. This is a patient with the following ventilator setting. FiO2 was 40%, PEEP was 5, respiratory rate was 12, and tidal volume was 450. We did one ABG 3 hours after the ventilation. We showed a pH of 7.10, which is acidosis. So that is not normal. We had a PO2 of 120. For a 40% oxygen, PO2 of 120 is good. Probably we can come down to the FiO2. But when we look at the PCO2, we can see that the PCO2 is high. We expect a value something around 35 to 45. In our patient is going to be around 90. So what we can do? As I said before, by manipulating the respiratory rate or the tidal volume or both, you will able to adjust the PCO2 of the patient. It's the second patient, the same setting, FiO2 of 40, PEEP of 5, respiratory rate of 12 and tidal volume of 450. We have taken an ABG after 3 hours. The pH was 7.34, which is okay, good. The PCO2 was 40, okay, it is good. But the PO2 is only 50. So getting a PO2 of 50 in 40% oxygen is not good. That means that we are having a hypoxia. So we can either increase the FiO2 or we can increase the PEEP according to the compliance of the lung. So most of the time in case of hypoxia, we will try to increase the PEEP if it is not contraindicated. So coming to the second question, how to know whether I am harming my patient? Again here we have to follow our pressures. I said we are having 3 pressures, the P peak, the P plat and driving pressures. So here is a scalar diagram. In the y-axis we are having pressure, the x-axis we are having time, y-axis we are having pressures. So in each breath we can see a graph like this, especially if you are applying inspiratory hold. We are having the highest most pressure, which is the PP, and we are having a pressure which is constant throughout a particular time of the inspiration, that is during the inspiratory hold. This is known as the P plat. As I said before, P peak means the pressures in the endotracheal tube, trachea, bronchi, circuit and HME filter. And P plat means the pressures in the alveoli. So we always want to keep the P plat within normal limit. So always try to keep the P plat less than 30 centimeter of water, and always try to keep the driving pressure less than 15 if possible at all. This is not a magic number, but still we can follow it. So this is an example. At 8 a.m. the patient P peak was 24, was okay. We had a P plat of 16, that was okay. And around 2 o'clock we repeated it, and we saw in the ventilator the peak increased to 38. So it is an increase from 24 to 38. So the P peak is increased. The P plateau is writing 18, so it is almost within the normal, it's not much increase. So we are having a case where we are having a high peak pressure with almost normal plateau pressure. So again the problem is going to be your airway. So if you are having high peak pressure, just check whether the patient is having bronchospasm, can give bronchodilators, whether you are having secretions or pulmonary edema or mucus plug in the trachea, or you can check whether the patient is having any kink in the ET tube, whether the patient is biting the tube. You can sedate the patient, find out whether any kink is there in the circuit, try to remove the kinking, and check whether your HME filter is clogged or not. This is another scenario. On day 1 we had a P peak pressure of 30, that is fine. The P plat was 18, that is also fine. But in day 3 we can see that the P peak is 34 and the P plat is 30. So basically you are having an increasing P plateau and P peak is almost remaining the same. So the problem here is with the alveoli. So what are the causes? Anything which fills the alveoli. Can be pulmonary edema, it can be inflammation, ARDS, can be blood, it can be pneumonia, or it can be fibrosis. So I told you how to ventilate the patient and how to know whether you are ventilating properly and how to check whether we are harming the patient. So putting these things together, we can see a patient at 8 a.m. the FiO2 was 40%, tidal volume was 450, respiratory rate was 12 and PEEP was 5. We did an ABG during that time. We showed a pH of 7.32, PO2 was 102, PCO2 was 40. In ventilator showed a P peak of 30 and P plat of 16. So that's looking okay. Maybe we can come down on the FiO2. But when you repeated the ABG, the same settings after say 6 hours, the pH came down to 7.10. So the patient is having acidosis. The PO2 reduced to 60. So patient is having some amount of hypoxia. The PCO2 is increased from 40 to 90. So there is a problem with the carbon dioxide washout also. So we know the patient is having hypoxia and hypercarbia. When we look at the ventilator graphics, we can see that the P peak is remaining almost the same, but the P plateau has increased. So probably our patient is having a progression of the ARDS, can be a case of pulmonary edema or some problem with the alveolar level. Thank you.